Okay, so good morning, everybody. My name is Kunal Kothari, and I will be chairing this session. And I'm honored to introduce the keynote speaker, Dr. JD Polk, who's going to talk about medical support to the ISS and the Artemis missions. Dr. Polk is the agency chief health and medical officer of the National Aeronautics and Space Administration, located in Washington, D.C. He began serving this position in November of 2016. Dr. Polk is well published in the fields of emergency medicine, disaster medicine, space medicine, and medical management. He's a clinical associate professor of emergency medicine at the Edward Weir College of Osteopathic Medicine. He has received numerous awards and commendations, including the citations from the Federal Bureau of Investigations, White House Medical Unit, Association of Medical Services, U.S. Air Force, and has received the National Center Director's Commendation, the NASA Exceptional Service Medal, the National Security and International Affairs Medal, the NASA Exceptional Achievement Medal, and finally the NASA Outstanding Leadership Medal. Please welcome Dr. Polk for his speech.
Thanks, Kunal. I appreciate the intro. I'll try to limit all those medals and awards in the future. Try to make that shorter. But let me see if I can share my screen here. And Kunal, if you'll just do me a favor and let me know when it shows up,
Sure.
and if my PowerPoint is showing up and looks decent.
Yep, we're good.
Great. Well, thanks very much for that intro. We're going to talk a little bit about all the things that are going on in human spaceflight right now, whether it's the commercial crew, the International Space Station, and Artemis missions, and touch on some of the medical aspects, but also a lot of the innovation that's occurring as part of that. And this is a very dynamic time at the agency. We have a lot of vehicles that we are in the midst of building. In addition to taking care of the astronauts, as one of the flight surgeons and chief health and medical officer overseeing that care of the astronauts and their waivers and the health care for the agency, we're also the tech authority, the health and medical technical authority, which means we have our flight surgeons and our folks weighing in on the human factors and human systems integration of these new vehicles in development. So we try to make sure that they are designed with the human in mind and work with our engineering and safety counterparts on the development of those new vehicles. This is what a lot of people think that we do, but probably it's a little closer to this. We do a lot of things to provide healthcare for the astronauts, but a lot of that is preventive medicine on the ground, and then, of course, doing space medicine while they are flying. But also there's procedures and requirements and standards that we work on. On the left side of that screen, we're doing intubation in what's called the Vomit Comet, that aircraft that does parabolas that can give you some microgravity or zero gravity on the way down for about 30 seconds when it's on the bottom half of that parabola. And we are testing procedures, something as simple as eye drops. Eye drops don't drop in space. And so you have to figure out, how do you deliver something like eye drops to an astronaut who's in microgravity? And that slide on the right, or the picture on the right, we're monitoring a spacewalk that's going on during one of the early expeditions of the International Space Station. And there's just a whole host of things going on in the commercial sector. Virgin Galactic, of course, had another flight with passengers just 2 weeks ago, and a very successful flight with 4 people in the back. And that's for suborbital, going up just to the edge of the Kármán line, or just above the Kármán line, and then down. Doesn't last very long, about 5 minutes of microgravity, but lots of folks starting to sign up for that, and you're starting to see this expansion of commercial spaceflight, especially in the suborbital realm. That includes Blue Origin. Blue Origin, of course, is also going up above the Kármán line, again in a suborbital flight, 5 minutes of microgravity, and then back down. Many of you probably saw last year where William Shatner, i.e. Captain Kirk, flew on Blue Origin up, and again, they are going to space, but they're not there very long. And so obviously the medical requirements for somebody doing a suborbital flight are different than someone doing a long duration space mission. There's not a lot of impacts physiologically, other than maybe a little, your stomach moving upwards into your throat. Some folks might get a little nausea, but that's very short-lived on this very short suborbital flight. Elon probably needs no introduction, but of course, SpaceX, we use SpaceX as one of our contractors. The vehicle built to our standards and requirements, we give them leeway on how those vehicles are built or how they meet those standards. This way, all the vehicles look different. But that SpaceX Crew Dragon is what takes our crews currently to the International Space Station. And so we just had SpaceX 7 crew launched to the space station and brought home the SpaceX 6 crew from the space station this last month. And that vehicle has been a great vehicle for us to ferry the crews back and forth to the International Space Station. Boeing has done 2 uncrewed test missions, and we're hoping in the spring that we will have the crewed flight test, what's called CFT, and that will have a crew on board. And again, then once Boeing is done its crewed flight tests, then Boeing will also ferry crews back and forth to the International Space Station. We'll have both Boeing and SpaceX, as well as the Soyuz, ferrying crews back and forth to the space station. Sierra Nevada and Sierra Space are creating a vehicle that is going to initially be cargo. It's like a miniature space shuttle or a space plane type vehicle versus the capsules. But it can be human rated as well. And so initially that's going to be a cargo vehicle, but they have the capability to eventually morph into human rating down the road should they decide to do that. But there's a lot of things going on the space station side. We have what are called CLDP programs, which are essentially commercial modules that will become small commercial space stations. And many of those are using inflatable modules. And we have an inflatable module that we have tested on the ISS as well. The International Space Station itself, flying at 250 nautical miles, 17,500 miles per hour, with over 32 countries contributing to that vehicle, the size of a football field and 24 years and counting. And that vehicle has been a tremendous asset for us as a national lab. You can create things in microgravity that you can't create on the ground, especially new crystalline structures. And that has implications to things like pharmacology, as well as material science. And so it's actually a national lab for us, doing a lot of different research for NIH and human health research as well. And then, of course, NASA's Space Launch System, that is the vehicle that will carry us back to the moon. With Artemis 1 completed, which was an uncrewed mission. And I have to tell you, that was one of the cleanest missions I have ever seen on a NASA vehicle. It's a beautiful vehicle. And we're working diligently towards Artemis 2. And then eventually we will have what's called the Gateway, which is this kind of miniature space station module, but with a power and propulsion element that allows it to fly more like a spacecraft than the ISS does. And that will allow us to dock with the capsule, as well as have a lander and then a second lander docked to it as well. And that allows us to go to different points on the moon during segments or missions, and that will probably have crewed missions at around the 30-day or less, although we might expand that to 45 days, and it'll have a high ellipse orbit. And this is what Artemis 2 is going to look like. They're going to do what we call prox ops demonstrations, proximal ops between spacecraft, And then that vehicle will come out and around the moon, but the astronauts will not go down to the moon. And a lot of this is checking out that spacecraft and making sure the Orion spacecraft and capsule is put through its paces and able to do all the things we need it to do before we land crews on the moon itself. Then, speaking of Artemis 3, that is when we will begin to go to the surface of the moon. And there are two different orbits. The Gateway, that miniature space station type vehicle, is going to have this large elliptical orbit around the moon. And then this vehicle, the capsule, will come and dock with Gateway. And then, of course, the astronauts will depart Gateway on the lander, land on the moon, and then leave the moon and come back and dock with Gateway again when it comes back around. And then, of course, they can depart through the capsule and back to Earth. So it's got a lot of complicated pieces to it, but this allows us to go to multiple places on the moon. If you notice that change in that orbit, it would keep going around the surface of the moon. It allows us to get to the poles of the moon. The poles are very important to us because the poles have dark shadows that may allow water ice and their craters on the moon. And those are areas that we want to experiment and look at sustainability of operations on the moon. And part of that is to make sure we are practicing for Mars. And so a lot of why we're going to the moon is to use the moon as a test bed for Mars. And it's not going to be quite like the 1960s missions. We're going to have vehicles like this pressurized rover. The landers will have a lot higher capability. We'll be doing a lot of science, but also a lot of testing of industrial engineering, power plants, even nuclear power potentially on the moon, to get us prepared for the ability to live and work on Mars. And so a lot of that expedition on the moon will be test beds and proving proof of concepts. Of course, we do more than just human missions. We're using robotics, and we will use robotics on the moon as well. We have rovers right now on Mars. We have telescopes that are exploring the universe, such as Hubble, Kepler, and of course JWST. Kepler was important. It was what we would call a planet hunter. It could find planets in the Goldilocks system, and this is one example of that, where Kepler found 7 planets in one system that were within the Goldilocks area, that areas that might potentially be able to sustain life and water and oxygen. And JWST has been just an enormous boon to us from a scientific standpoint, making discoveries in the galaxies that we have not been able to do with any previous telescope, including Hubble. And the mission is giving us resolution and photos of the galaxies that we have never seen before. And it's been just a scientific discovery every day that we get data back from JWST. And the fidelity of the photos and the fidelity of the information and data we are getting back is just phenomenal as well. But we still have some workhorse missions, that are still sending back data, including Voyager 1 and Voyager 2, that are sending data all the way back from the edge, departing our solar system and moving out into the galaxy and still sending data back, which is pretty phenomenal as well. For the astronauts, space is a pretty unforgiving environment with microgravity, and especially when you're there for long duration missions. You can have decrease in your bone integrity or strength because you're losing some calcium from those bones. So the astronauts are doing a lot of exercise, including resistive exercise, to lay down calcium and to make and prevent that bone loss. That calcium gets cleared through the kidneys, so they're at risk for kidney stones. They have this fluid shift up into their head and thorax that can cause puffiness and can also increase the amount of fluid around the brain and around the optic nerve, which can cause vision change and other issues with the astronauts. And so the flight surgeons do a great deal of space medicine to prevent and mitigate untoward effects of these physiologic changes in microgravity. And of course, radiation is something the astronauts are exposed to as well, and we worry about their exposures and try to mitigate harm to the astronauts whenever possible. What we call SANS or VIP, that is actually spaceflight associated neuroocular syndrome or vision impairment and intracranial pressure. And that's due to that fluid shift moving up into the head and thorax. If you look down here at the eyeball, normally the eyeball is round, that globe is round, and eye is, the sunlight is coming through your eye and is focusing on the back. The image is focusing on the back of the retina. But when you have the swelling of the optic nerve, this nerve behind the eye, if it swells a little bit, it pushes that eyeball forward. You notice how this is more flattened globe here. You could literally put that eyeball on a table and it wouldn't roll because it's a little flat. That actually moves, if you will, the screen, the retina, forward a little bit. And so it moves it out of focus. If you think of the focal point being back here where your eye focuses an image, now I've moved that screen forward due to that swelling of the optic nerve. And so that can shift an astronaut's vision by what we call diopters. If you've ever been to the eye doctor and they say, is this one better or this one better? That's a half a diopter that they are looking at and flipping back and forth through diopters to see if your vision is clear. And so it can change the vision of an astronaut on orbit. We also see what are called choroidal folds, which are, think of it as wrinkles or folds in the back of the retina due to that swelling in the back of the eye. And those typically don't go away. Once you make a fold back there, those are semi-permanent. They may soften a little bit, but they typically don't go away totally. And you can get what are called scotomas, which are blind spots. So there's a lot of things that we worry about with this shift of fluid and intracranial pressure to astronauts. But we're looking at mitigations such as a medication called a GLP-1 agonist, to see if that will lower the cerebrospinal fluid in the brain and decrease the amount of fluid and pressure from spaceflight. But also artificial gravity would be another thing that would hopefully help with that. But artificial gravity, one of the biggest reasons we don't have that on spacecraft is that takes a huge amount of mass and engineering. It would be very expensive to be able to do and rotate that spacecraft like they do in the movies. Maybe eventually we'll be able to do that, but we're not able to do that right now. Impacts to design. This is, on the top, you see what an astronaut might see on launch. But after they have that vision change, you can see how this is about a diopter or a diopter and a half change. And so flying different prescriptions for the astronauts and potentially being able to use a medication or artificial gravity or lower body negative pressure to reduce that swelling in the back of the eye would be important for us to do, especially before we get to Mars. Neurovestibular function, the astronauts, when you're not using your eyes and your middle ear and other things to keep your balance like you are on the ground, you can get a little bit of neurovestibular function. That includes horizontal nystagmus and what are called saccades. And that's what you see here with that eye twitching up there above. And it can throw your balance off. But as we try to mitigate that for the astronauts, part of it is getting them to walk on a treadmill, but getting them to see or have a false illusion of traveling somewhere might help with virtual reality. And we're looking at virtual reality goggles and other things that will help keep that association of your vision and your movement and your neurovestibular system intact. Bone loss, we've talked about a little bit with that, the calcium being absorbed potentially through the kidneys and the decrease in calcium in the bone and how that can weaken bone over time. And using both medications, diet with vitamin D and resistive exercise, we can mitigate that to a fair extent, especially on the ISS. But there's a lot of technology that we use as well, and technology demonstrations that we are developing for Artemis and for the lunar missions. But there's a lot of things that we develop at NASA that also carry over to the ground that many people may not realize. And a lot of these technologies we're using right now and developing with those Mars missions and eventually getting to Mars and what we call moon to Mars architecture as part of our development process. And just to give you an idea, this is the space shuttle main engine. Big, massive engines that we had at the back of the space shuttle to boost that vehicle into orbit. And you wouldn't think that that applied much to medicine, but it actually did. This is I don't know if I'll see if I can move that little. Let's move that over there. This small little engine here, Dr. DeBakey was having problems when he was making what's called a left ventricular assist device. That's a device that helps pump blood when your heart is failing. And he was having trouble making that device so that it would pump blood without breaking those red blood cells, what we call lysis of the red blood cells. Because a propeller, if you think of a propeller, it chops, right? A propeller on a boat chops the water, and that's how it propels the boat forward. But what you want is an impeller, one that spins and starts to stack a fluid. And fluid dynamics, what we call a rouleau formation, where red blood cells can stack upon each other without breaking them. And he was having trouble making that impeller, and he turned to NASA for that. And the same type of impeller that is in that space shuttle main engine, the same type of engineering design and shape and fluid dynamics to propel that rocket fluid up into that engine as the rocket is going quickly up into orbit and all the gravity's going back to the back of the spacecraft. You want to pump that fuel forward. And we do that with an impeller on the space shuttle main engine. And we also do that with an impeller on the SLS engines. That same impeller miniaturized is what's part of the left ventricular assist device. So even the space shuttle main engine has an impact into healthcare and medicine. And let me see if I can get to the next slide here. There we go. The robot arm, you've probably seen Canada with its large robot arm on the International Space Station. That same program that tells that arm where to go is used in a medical device. And as you can imagine, the International Space Station, as a reminder, is flying at 17,500 miles an hour. So you don't want this arm out there whipping an astronaut around, and you don't want it to collide with the space station or with hardware or with the satellite. So it's very precise in where it moves that astronaut to and in the amount of speed and pressure that it uses. And that same software is used in this particular robotics for neurosurgery. And so that development of that software to move that robotic arm in space is still applied again on the ground into medical hardware. And carrying on, this is an ultrasound, what's called CIMT, carotid intimal medial thickness ultrasound, where it's looking at multiple different shades of gray in the vasculature and the artery. So we can see how much plaque you might have in this layer of what's called the intima around an artery, and looking at cardiovascular disease. And it can evaluate over 150 different shades of gray to identify which one is plaque in that artery. And that same program, that same software was developed at NASA, and it was developed to look at 150 different shades of gray in planetary science, but then was taken to healthcare. Again, another example of NASA innovation going to healthcare. But there's no sticker on that ultrasound, and when a patient gets that CIMT ultrasound, there's nothing that says, oh, by the way, this was developed at NASA for planetary science. We've also looked at developing ultrasounds that not only do imaging, but can also, for example, move a kidney stone, and to be able to push that stone out of the duct and out of the ureter. And then also use high intensity focus ultrasound. We've looked at this as well, where you can take multiple different ultrasounds, and where that beam crosses, it can produce heat. And think of it as the ability to cauterize a wound without opening the skin. So imagine somebody who's had trauma, an astronaut rolling over a vehicle in a crater on the moon or on Mars. Whereas right now we would need to, either through a catheter or through surgery, stop that bleeding in the liver or the spleen. Imagine being able to use a device that uses 3 different ultrasound waves that, when they cross, create heat and cauterizes that wound. And we've done experiments with that. This is the pig experiments down here, looking at how we do those types of technologies and how we might be able to utilize that for the future on the moon and Mars. So, surgery would be pretty messy, and it takes a lot of equipment when you do surgery with suction and scalpels and things of that nature. But if you could actually use the ultrasound to cauterize that wound and not have to open someone up, that's a big deal, and would also have impact on the ground here. But we've also worked with ultrasound makers to miniaturize ultrasound. And when the International Space Station started, the ultrasound was the size of an entire rack, and then got down to the size of a washing machine. And now this is James Patarini, one of the flight surgeons with flight surgeon turned astronaut Serena Anand. And he is doing an ultrasound in the tent. This is after she's landed on the Soyuz. And he is using what's called the butterfly IQ, where all the ultrasound, the things that used to take an entire rack or be the size of a washing machine, are now in this probe itself. And then the iPhone is used just as a screen. So imagine the entire ultrasound going from the size of a washing machine or the size of a rack down to now all of it being contained just in the ultrasound probe itself. And so that's a lot of mass solved for us. And when you're flying something to the moon or Mars, the amount of mass and volume matters a great deal. Of course, development of robotics is something that we've done as well. This is Robonaut on the left side. And you notice that Robonaut has hands that are similar to human hands. And that's so that Robonaut can use the same tools as the astronauts. So we don't have to fly different tools. And the idea will be to have robotics such as Robonaut or some of our other robotics that we are developing that will assist the astronaut on the surface and be able to haul different items, or be able to use different tools, or be able to help repair a spacecraft on the way to Mars. And again, this is some of the tools that Robonaut is able to use, and that was a partnership with GM. But also those haptics, those software and haptics that we have developed for allowing that robot to use human tools, carry over into the software and the haptics for prosthetics. And we've come a long way from someone using a hook or just a squeezing adaptive modality for a prosthetic. The ability to do fine dexterity and pick up something like marbles, or screw a part onto the end of an end effector. That is coming about, and a lot of that due to the haptics and software, again, developed for robotics, and many of that done at NASA. And of course, working with DoD and others as we continue to refine our robotics and our haptics, important for those that have lost limbs, both in the military and elsewhere. This is Valkyrie. Valkyrie is the full-size robot, includes legs and the whole works. And Valkyrie can walk, talk, and will be able to carry and has stereoscopic vision. And so this is something that we've been working on. And it's worked on with multiple different university partners, including in Scotland at University of Edinburgh and Glasgow, and other places throughout the world, working together with us, developing the robotics for the moon and Mars. But also using exoskeletons. As you can imagine, the astronauts might have some weakness in their lower extremities or in their muscles or legs. And having an exoskeleton attached to their suit when they first get to Mars, that could be helpful. But that also has carryover to the ground to help paraplegics be able to walk with those exoskeletons as well. 3D printing is something that we are working on actively with multiple universities. This is Wake Forest using printed skin directly onto a burned limb. using stem cells and as the feedstock. And you can imagine all the different implications that this may have. This is Redwire, and this is on the International Space Station right now. The crew installed this bioprinting fabrication facility on the space station 2 weeks ago. And we're doing activation and checkout with that hardware. In about 2 months, we will actually print a knee meniscus on orbit using, again, stem cells as biostock, but being able to print an actual cartilage of a knee meniscus on the International Space Station. So think of the implications for that. As you get older and your knee meniscus wears out, instead of having to just have it removed and have bone on bone, or have a pig tissue or something that you might reject, being able to take your own stem cells, take blood from you, spin it down, take your stem cells, and grow your stem cells and use it as feedstock, and then bioprint a knee meniscus. Think of the implications of that for the future, whether it be bioprinting of a heart valve. Most of you know that we've used pig valves for many years, and now we've used mechanical valves. But imagine being able to bioprint a heart valve from your own stem cells, where you would not be able to reject that tissue, and it would be actual bioprinting. And those are a lot of the areas that we are working on right now. This is an actual working kidney that was bioprinted. Think of people that have lost limbs or digits, cancer that might cost somebody a nose or an ear, to be able to bioprint those areas. And of course, bioprinting surgical instruments. If we forgot a particular surgical instrument, we could bioprint that on Mars or print that particular material. This is 3D printing of medications. I can't take the entire CVS and Walgreens pharmacy with me to Mars. That's too much mass. And so we could take perhaps 20 constituent chemicals, and if you've got the right recipe, 3D print a medication. So imagine being able to 3D print penicillin or Cipro or amoxicillin on Mars on demand, and also think of the implications that would have on the ground in third world countries or in other places, to be able to 3D print medication on demand if they've got the constituent chemicals. Telemedicine, this is one of my colleagues, the good Dr. Joe Schmid. That ghostly image is him on the International Space Station, but Joe was actually sitting in Houston. And this is using the Microsoft HoloLens and being able to literally project himself as an entity onto the ISS and have a conversation with the astronauts on the ISS as a hologram. And Joe recently did a lecture at a university while he was in Russia at Star City, and projected himself at the podium, again, using the HoloLens. So some amazing developments in technology in both virtual reality and other places now occurring. And we've tested many of those technologies. Joe himself has tested several of these technologies on the space station. This is what's called MCOG, which is a mobile concentrator of oxygen and oxygen generation. So that box, about the size of a desk, can actually produce enough oxygen for a medium-sized hospital. So we would use that device to produce oxygen for a space station and or an outpost, say on the moon or Mars. But imagine being able to actually make enough oxygen using household power for a medium-sized hospital. Right now, we have all these big green tanks, right, that are shipped by a truck, and you have to each week bring in new tanks to fill the oxygen and for the ICU and the ER and throughout the hospital when patients are on oxygen. Imagine being able to just generate that without going back and forth with the trucks and et cetera, to be able to generate it on site with household power. And that's what the MCOG is capable of doing. And again, looking and testing different abilities to produce oxygen. This is MOXIE, and MOXIE is on Mars. And what MOXIE does is take CO2 that is in the atmosphere of Mars and it changes it and cleaves it and produces it into oxygen. And so that device, does a great job of turning CO2 to oxygen. Imagine that on a much larger scale and what the impacts might be for climate change are. If we can start to scrub the atmosphere and scrub excess CO2 and turn it into oxygen. Of course, God's pretty good about doing that with trees, it took us a lot of engineering to try to duplicate that, but much as a tree turns CO2 into oxygen with photosynthesis, Moxie does that same thing. And that would be important for us, especially on Mars, to create oxygen for fuel for rockets, as well as oxygen for astronauts. But we're also pushing a lot of the boundaries. Again, this is cardiac stem cells. These are 3D printed beating cardiac stem cells, again, from Wake Forest Institute of Regenerative Medicine. But we're doing some of that same type of research. This is Dr. Kate Rubins on the International Space Station, sequencing the DNA and growing cardiac cells on orbit. And so we have been able to do a lot of that same science, but to do it in microgravity and to see how those cells respond in orbit as well. NASA, of course, one of the biggest things that NASA does is NASA is a soft power of exploration. We are not the military. The biggest thing we are doing is exploration and scientific discovery, but it also, gets people excited about STEM. And everywhere I've gone, whether it's been the mines of Chile or whether I'm in any country, it's often that I see the NASA logo sported on kids' shirts or jackets or somewhere. And that's because I think NASA, because of its exploration and innovation and scientific discovery, inspires people around the world. And of course, our programs are international. And we have included the bulk of the world and many of our programs, and we'll do so again with Artemis and going back to the moon and to Mars as well. And so with that, let me stop there and see if there are any questions. Let me take this down. I think we're still right on time. And I'll quit sharing. There we go. So Kunal, you can probably see better than I can. I'll look at the chat and see what we have. Thanks, Dr. Nikogosian. Dr. Nikogosian, by the way, was my boss's boss for many years. And Dr. Nikogosian and I have worked together on textbooks and many things, but he has been the shining star of NASA for many, many, many years as the chief of space medicine, as my predecessor. So I'm very honored to be in his position now.
We have a couple of questions. There's one from Gabriel Ryan. Can you comment on psychiatric care or monitoring in space and the efficacy, if they are used, of antipsychotics and antidepressants of various classes in microgravity?
Yeah, Gabrielle, that's a good question. One, I can tell you we don't use antipsychotics and antidepressants in microgravity much because we screen out. We wouldn't be flying anybody who needed an antipsychotic into the International Space Station or into space. And so we do have a rigorous selection process. But of course, with commercial crew, right, they're going to have, as it evolves and as that industry continues to evolve, they'll fly more things that NASA did not fly, because we are making sure that the astronauts are healthy for a long term. But if you're going to do a short-term mission and you're paying money to go up, they're probably going to fly more pathology that we didn't fly. So we'll be interested to see what lessons learned they have when they do those things. But the psychological support for astronauts, there are a couple of things that we do. One thing that really helps is for them to stay connected to family and to the ground. And so we have what's called an internet protocol phone. They can call family. It shows up as a Houston area code. I've gotten calls from the astronauts from the International Space Station on my cell phone. And we also send up care packages. They have all sorts of things that they do for their wellness. But I'll tell you, one of the things that they have remarked about is exercise, that those periods of exercise, in addition to bone and muscle strength, that really helps their mental health a great deal. And so that's something to think about as well, is that exercise plays more parts than just the physiologic muscle and bone aspects to it. But great question.
We have another question by Daniel Evans. This is regarding robonauts. Astronauts typically have relief crews that assist them to return to the surface of the Earth. Do you think robonauts will be capable of assisting them in readjusting after 8 months trip to the Martian surface? And to what extent do you think that may be possible?
Yeah, I'll tell you, as most of you know, I mean, think about just 5 years ago, right? Most of us had heard about artificial intelligence, but it was mostly in the movies and other things. And then all of a sudden, in the last year, Chat GPT just exploded, and we've had AI. You can make AI pictures. You can do all sorts of things that you couldn't do 2 years ago. The technology is evolving so quickly that I do think, and if you look at some of the robotics technology occurring at MIT and elsewhere, um, when we do the Mars missions, I do think we'll probably have whether it's Robonaut or whether it's the Valkyrie robot, the full size robot. I think we'll have some assistance from robotics. If you can imagine the astronauts doing what's called a spacewalker EVA on the surface, and having the robot helping packing tools or packing samples, or helping to scan for threats, looking, monitoring radiation, doing all sorts of things there. So I think there's a lot of capability yet explored with robotics that will assist the astronauts. But without a doubt, I think there'll be a place for that in the future. We can see where the technology is going right now and see how rapidly it's evolving. I can't imagine we wouldn't have some assistance from them there.
Great. The next question we have is from Eric Pitchler. Do you think artificial gravity will ever become a reality for reducing maladaptive physiological effects of microgravity during deep space exploration missions?
Yeah, it's a great question, Eric. I think it will, but it will take a great deal of effort and money. And this is thanks for students. If you go to a website called SpinCalc, 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 you can actually put in there and figure out how large of a radius arm would you need on artificial gravity to get 1G. And remember, it's not just 1G at the head or the foot. You're trying to get 1G at what's called the left atrium of the heart. And there's a, when we're on the ground, there's actually a very minuscule change between the gravity at our head and the gravity at our feet. But Earth is so large, it's minuscule and we don't even realize it. But when you've got artificial gravity, that, all that blood moving towards your feet, you want blood in your brain. You don't want to pass out. So there's that happy medium of getting that artificial gravity at what we call the left atria. And you got to spin, and that radius will probably be about 220 meters long. And so if you think about, if you do that calculation in SpinCalc, you'll see that it's about 220 meters long, and you don't want to spin any faster than 2 revolutions per minute, because if you spin faster than that, you're activating the Coriolis effect in the middle ear, and people are leaning, to one side and feel like they'll get dizzy. So you have to get that happy medium of getting artificial gravity, but not having it spin too fast, and not having it long enough so that you've got a little bit of a gradient between the head and the feet, but not too much. And so to do that, that's a pretty big vehicle, unless you're going to spin or rotate the entire vehicle. And also, when you're spinning in space, let's say we're going to some planet, and I've got this big spinning wheel, or paddle wheel, if you will, giving artificial gravity, that can cause changes in momentum in the spacecraft so that you actually would have to have what's called CMG, control moment gyros, that would keep spinning to keep the spacecraft on course so that it's not taken off course by that spinning artificial gravity. But all of those things, Eric, would have to come together, and that's some expensive engineering. We know how to do artificial gravity. The question is, NASA doesn't have quite that many billions of dollars to be able to put that on the spacecraft right now. But hey, you want to write your congressman and tell him to give us triple our budget? Let me know. We'll get in on that.
Sounds really fascinating. We have one more question from Gareth Kolyamer. Sir, what level of medical capability will we expect astronauts to maintain for a Mars expedition?
Well, that's a great question. Right now, the crews on the International Space Station are educated to the level of an advanced paramedic. Now, we do occasionally fly a physician on board there. We do have physician astronauts, but when we go to Mars, that's going to be more important because right now on the space station, we can support them on the console as flight surgeons. We can give them medical instructions and tell them what to do medically. But when you get to Mars, it's a 20-minute delay one way and 20 minutes back. And so, and you can't just take off from Mars if something goes wrong. Mars and Earth don't line up again for 18 months. So when you go to Mars, you're there for the duration until it's time to come back and the two planets line up again. And so those folks will have to be educated to the level, at a physician level, but also be a little bit of everything, right? They're going to have to be part dentist, part OB-GYN, part emergency medicine physician. And so we'll have to develop that curriculum for those physicians to learn and to be able to supply that medical care on Mars.
So further, probing a little further on that, Kristen Miller asks, if the telemedicine and holographic medical consults, how can they be adapted for missions with significant time latency?
Oh, that's great. Great question. And I see Professor Chuck Dorn is also in that chat down there. Chuck's worked with the space program for over 30 years, and Professor Dorn's probably the expert on telemedicine. And so, Chuck, you're gonna have to tell me if I do a good job on this one. But I could see the holographic or the telemedicine, although much of it is real time right now for the International Space Station, and maybe with a second or two delay for the moon. I could see just-in-time training where we would have video or holographic areas. If you're an astronaut on Mars where you haven't done a chest tube in 2 years, but you've got a virtual assistant that could walk you through it, that will be on the computer and kind of show you how to do that chest tube using virtual reality or a video over top of it while you're in real time. And so, a lot of that's going to change, especially with the evolution of technology, with where we're seeing VR, telemedicine, chat GPT heading. And that will help augment the astronaut for sure when they're on Mars. Oh, you're muted there, Kunal.
So we have one more question from Charles. Can you envision medical education changing to include more autonomous support based on the needs for medical care on Mars, since there'll be a delay between MCC and the surface?
Yeah, and much thanks to Professor Dorn for that question. Absolutely, they're because of that delay. Think about a code, right? I'm not going to have a flight surgeon on the ground saying, "Okay, now shock them." Well, it's 20 minutes before that message would get to Mars, and 20 minutes back. So you can't say, clear and then wait 20 minutes. So it's going to be to where those astronauts are going to have to be fairly autonomous, including with autonomous leadership. Right now we plan almost every second of their day on the International Space Station. We're watching all the switch throws that they make. We have people on console able to walk them through a procedure on a spacewalk. We tell them go to step 9 on page 12 for that procedure on a spacewalk. they're going to have to be much, much more autonomous when they're on Mars. We're not going to be able to give them step-by-step instructions, and they're going to have to problem solve when things go wrong. And that's going to require a lot of autonomous training, including in medical care. I'm scanning through here too, Kunal. I'm looking through, see if there's anything else you want me to answer or not.
Sorry, my connection was not good for a bit. I think we have one more last question. I think Daniel is repeating a part of his question again about replacing astronauts with AI. So the end of astronauts, he's referring to this book with the resurgence of AI and rapid advancement in technology, not to mention the fragility of the human form. Does NASA take the possibility of human exploratory replacement with AI seriously?
Well, let's talk about that for a second. So, yes, AI and robotics. We've had that question, age-old question, right? Why send astronauts? Why don't we just send robots? Um, it takes a robot on average about 8 months to do what the astronauts themselves could do in 2 days. And so that's one of the biggest reasons to send actual astronauts to the surface. But also, the astronauts can problem solve and do context right away. If the drill gets stuck, the robot's sending a message back to Earth that says the drill is stuck. But the robot itself isn't able to problem solve as well as an actual astronaut would be able to do. And plus, there's the ability to actually morph the atmosphere, produce oxygen, do other things. This planet, we're finding out, is pretty fragile. We got a pretty thin blue line, and there could be things from an asteroid to World War III to other things that might put this particular planet at risk. And so potentially moving to a multi-planet species is something that also helps save the human condition in itself, but also allows us to learn more about this planet as well. And so there's a lot of different reasons to fly humans. And humans, physiology can be a little frail, but we learn a lot from the International Space Station and from the Moon and Mars. It allows us to figure out how to adapt. And humans as a species are pretty adaptable.
Great. One more question from Christopher. He's asking if a space suit capable of producing oxygen, are we close to, is it possible to have something like that?
Oh, that's a great question, Christopher. Could you take Moxie and miniaturize it and put it in the spacesuit itself so it could take the CO2 of Mars and produce the oxygen? Hey, I'm writing that one down. I'm making a note to myself on that one. That would be a great addition. Right now, what we have is the ability to recharge the spacesuits using MCOG and other oxygen concentrators. And be able to plug in and recharge the O2. But I like that idea of maybe we could miniaturize Moxie and put that on the spacesuit itself and let them produce their own oxygen as they keep walking. Great idea.
Right. I just had a final question. Was when they were conducting these tests on growing stem cells on the ISS, was there a difference in terms of how easy it was to do 3D print versus on Earth under gravity?
Yeah, it's different. I'd have one of the structural engineers who could probably elucidate it better than I can. You're relying on a couple things. You're relying on surface tension for that printing because gravity is not, it's not like you're squirting it out and gravity is causing it to mash down. So you're relying on surface tension between the two substrates for one. And so it also, gravity has a way of smoothing out or sedimentation occurring with cells or substrate, and you don't have sedimentation occurring in microgravity. So it looks a little thicker and maybe a little fuzzier on the edges than it would otherwise. And how those crystalline forms form are slightly different in microgravity as well, a bit more interlocking. And so it is different. And that's part of the reason that we're doing these experiments in microgravity, is to identify what the different structural differences, both if we 3D print metals, if we 3D print plastics, but also if we 3D print bioprinting with cells, how that is different than on the ground, and where it may not work as well, or where it may work better. And so it may be that you want that sedimentation and fragmentation and layering if you're doing a structures material like concrete or titanium, or printing something of that nature. Whereas in cells, you may not want that. You may want those cells to be a little bit looser and have different types of bonds that might help them. We're learning a lot about 3D printing in that environment, but I don't know that you can say for sure that microgravity is absolutely better for X. I think it depends on what you're printing. It might be that on the ground is better for certain materials, like structures materials. In orbit is better for stem cells and other cells and how they come together. But we'll figure it out as we go through. It'll be pretty cool to see Redwire print, bioprint that meniscus on orbit.
Great, thanks for your answer. And I think we have one last one. This is, I think, with respect to the spacesuits, would there be any significant difference to chemical rebreathers, similar to, I guess, diving?
You mean like saturation diving chemical rebreathers? Yeah, I get the question there. For the most part, what we've had is we have used things like lithium hydroxide for scrubbing CO2 and stored oxygen for the suits, which limit the suit capability to about 6.5 to 7 hours before either you've got to recharge CO2 or you have run out of CO2 scrubbing capability. We have moved from lithium hydroxide canisters on the spacecraft and in the suits. But for example, on the Orion spacecraft, instead of lithium hydroxide canisters, it will actually use amine beds to scrub the CO2. And so as we've get more complicated to where we could use things like amine to scrub the CO2 real time, dump that CO2 over, outside the suit and keep that amine circulating, it might be able to extend the life of that suit. Same with the O2, if we're able to do something that looks like oxygen generation. But right now, think about how big that MCOG is, and even MOXIE on the rover itself. MOXIE, yeah, it's a pretty sizable device, fairly heavy, but also it takes a fair amount of time for it to produce enough oxygen there. For us to produce enough for a suit and be able to scrub the CO2 in a suit, we're not there yet. Could we be there for Mars as we continue to develop the technology? Certainly, we could try to be there for Mars, and that's one of the advantages, I think, of using not just NASA but the commercial sector. Right? We have our spacesuits that we're developing for Artemis. In fact, you've probably seen the Artemis 2 crew. If you Google the Artemis 2 crew, they just did a dress rehearsal for landing ops or for launch ops for the ground systems this last week, and you'll see them in their orange their orange suits that we have for launch and entry. We have our own spacesuits that we are developing for EVA, but we're also in our procurements tasking our contractors, the SpaceX, Blue Origin, others, to develop their own spacesuits for their landers and their different areas. So we'll end up with multiple different spacesuits. And the advantage to that is you get a little competition between folks and people get kind of innovative, right? I mean, think about SpaceX I mean, NASA had never had a booster that came and landed back on the ground or on a ship. SpaceX was the first to do that. And then we're all sitting there thinking, you know what, that's a pretty good idea. But then we have other things too that we do where SpaceX thinks, that's a pretty good idea. So, the more you get in this ecosystem or family of space flight, the more innovation and engineering you have. And so that cuts down the time to new innovations, I think. And so we'll see what happens with spacesuits, but it'll be pretty interesting to see now that it's not just NASA or Hamilton Sundstrand, it's multiple folks making spacesuits to see where that's going to go.
I think we reached the end of the questions. Again, I would like to thank Dr. JD Polk for taking the time and providing such an excellent presentation. I think we had amazing questions and great answers by Dr. Polk. Again, thanks a lot for all your time.
No, thank you. Thanks for inviting me. And thanks again to Dr. Nikogosian and also Professor Dorn online, for all their work and support for the space agency. And good luck to all the students that are in space studies. I will tell you, the environment is very large, and the ability to have a job in the space sector is ever expanding. That economy is vastly expanding all the time. So it's a good time to be in that profession.
Thank you, everybody.